I'm Professor Andrew Shennan. I'm based at King's College in London. I'm here at St Thomas's Hospital talking to you today. I've been asked to give a lecture about angiogenic markers, specifically looking at the ones that are currently available and a comparator between single markers versus the ratio. We all know that placental dysfunction is now fundamentally related to developing preeclampsia, and a lot of attention has looked at biomarkers related to the placenta to try and help in the management of this condition. So I want to spend a few minutes just looking at the clinical scenario and why biomarkers may aid in our management. We know that preeclampsia actually begins very early on in pregnancy, long before there are any clinical signs, and it is a most common theory is that it's related to poor placentation. At some point, if you have the syndrome of preeclampsia, you will manifest usually with the development of high blood pressure and proteinuria, but also a number of other clinical features. For example, the placenta may result in growth restriction and various other abnormalities in the mother. Almost invariably, if you get the diagnosis right, there will be a critical event that needs delivery to prevent a sort of serious morbidity or mortality occurring in either the mother or baby. And that crisis is obviously worth avoiding, and so at some point we deliver the baby to protect both the mother and baby if you know that preeclampsia is coming, and preferably at a time before there's a crisis, but as late as possible so that the mother or the baby is mature as possible. What it does mean is that for a large part of the disease process, we are aware preeclampsia is coming, but there are no clinical features, and it's really at this point where the biomarkers can be used to identify who is going to get preeclampsia. And it's really this new biomarker that's now been put into clinical practice. How are we going to use it? How is it going to improve our management? I think the other key thing is to realize that detecting this problem, detecting preeclampsia and those women who are going to get it, is really the key to improving outcomes. We haven't cured the disease, it is still there, but when it's managed well and we identify it, we keep people safe with antihypertensive therapies and sometimes anticonvulsants, and we instigate delivery in a timely manner, and that is a real lifesaver. And now in the UK, for example, only about 1 in a million women will die from this condition because of this judicious and appropriate management. So how might the biomarkers be used? First of all, they can be used in normal pregnancies, and they can identify women who are destined to get preeclampsia, particularly early onset preeclampsia, and there are now some prophylactic therapies, for example like low-dose aspirin, that can be targeted. FIGO actually recommend an algorithm to identify those at risk. The algorithm takes a number of markers, both biophysical, biochemical, into account to identify who's at risk. And you can see here on this slide that if you take PlGF alone, it has reasonably good prediction of who's going to go on and get early onset preeclampsia. And the majority of women can be identified. And by adding in things like blood pressure, Dopplers and so on, you can improve that prediction. But it is remarkable how the biomarker alone behaves well. And we certainly know that adding in the biomarker into any algorithm to target aspirin is a good idea. Perhaps the commonest and the most appropriate place to use biomarkers is in that group of women who present to us with signs of preeclampsia, but we're not sure how bad it is, we're not sure if it's actually going to be preeclampsia. So gestational hypertension, for example, is very common. Other features of preeclampsia like symptoms or even growth restriction, we don't know whether this is going to become a disease that requires urgent delivery or not. And using the biomarker in that suspected preeclampsia scenario seems to have the best clinical utility in terms of improving management, sending home the right people, bringing in the right people to watch closely and arrange timely delivery. What we do know now is that if you have a good diagnosis of preeclampsia, then the biomarkers don't add much to this group. They already are abnormal, and there isn't a lot of advantage in adding in the biomarker at this point. If you have good clinicians, you'll have abnormal biomarkers, and therefore there's very little discretion in risk stratifying within the woman with established preeclampsia, and we still rely on our old clinical acumen to decide when and who to deliver. And we've recently published a group of women in the UK who developed early onset preeclampsia, in fact 900 women. We took the biomarkers on them, the angiogenic biomarkers, and this work is now published with our health technology assessment work that I did with Lucy Chappell and our group. So we know that there are anti-angiogenic and angiogenic factors. We know the two commonest ones now that are now on the market are S-FLT, which will increase with risk, and PlGF, which will reduce with risk. And there's a considerable literature describing this. So we started work on this a while ago, and back in 2000, Lucy Chappell, actually as part of her PhD, very nicely demonstrated in longitudinal data that low PlGF was strongly associated with the subsequent development of getting preeclampsia. One of my other MD students, Claire Cookson, went on and showed again in very good longitudinal data that low PlGF was strongly associated with the development of preeclampsia. Subsequently, our colleagues in America in cross-sectional data demonstrated the same thing, and this was highlighted by getting a nice publication in the New England Journal, again demonstrating that PlGF was low right from the first trimester in those destined to get preeclampsia, and in established disease it was very low. Conversely, S-FLT in the same data set did exactly the opposite, and logically by taking a ratio of the two, one could augment the diagnostic potential of is this patient likely to run into problems. Now, there are many biomarkers out there that have been looked at over the years in those who may or may not be getting preeclampsia. And in some of the work we did earlier on, we actually took more than 50 of the most promising markers that were in the literature, and we looked at this as a way of trying to work out were there ones better than others, what would they be like in combination. What we actually showed was PlGF performed pretty well, actually. It was perhaps the best biomarker. There were another maybe 5 or 6 candidates that weren't bad, and we essentially combined them in multiple algorithms to try and get the best data we could. And the bottom line is we could only improve the sort of predictive capacity marginally. So we kind of came away from this thinking, well, PlGF alone was pretty much almost as good as putting 6 together, and obviously that's cheaper and simpler. And here you can see the ROC curve demonstrating that the red curve, PlGF, is pretty comparable to then adding in multiple other promising markers. And so that was very reassuring that a fairly simple test could be taken to market rather than having multiple tests, which clearly is more complex. You can see that the ROC area actually is much better than the clinical tests we use, and this is obviously an improvement on what we've been doing previously, the various sort of liver function and other renal tests, and even sort of blood pressure in predicting who's at risk. So we have a biochemical marker that is better than what we were doing previously. Now, the problem when you take this to the clinical arena is there are a number of biomarkers out there. Different companies are now marketing them. Some of them are doing the ratio of S-FLT to PlGF, some are looking at PlGF alone. And part of the problem is there are a number of types of PlGF out there. There are actually 4 isoforms, of which type 1 and 2 are the commonest ones that the assays use, and they may have preferential sort of effect in measuring these. And apart from the fact that there are different isoforms of the same agent, as it were, there are also big differences in the clinical studies that have been done. So when people have looked at these biomarkers in predicting preeclampsia, they've used different populations. So some studies will have very high prevalence of preeclampsia, some will have very low. And these really do drive the positive and negative predictive values, far greater than the actual predictive value of the biomarker, which makes comparing the studies incredibly difficult. The other issue is different studies use different endpoints. Some will look at development of preeclampsia in a week, some will look at it in a month. Others will look at different types of disease. So not only do we struggle to get a good diagnosis of preeclampsia, in some of our studies nearly 20% of the cases have to be adjudicated to get it right. And then you might add in the need to deliver, for example, which is obviously a clinical decision. So there are multiple reasons why these studies are very challenging to compare. And then perhaps another really important confounder is, depending on which clinical studies were done early on, there may be a threshold effect. So some commercial companies will use one threshold and others may use another threshold with different units, and it's really difficult to compare apples with apples here. So with that in mind, we actually wanted to do some comparator studies. Now to illustrate this, Peter van Dadelsen's group in Canada actually compared the PlGF as marketed by Roche with the PlGF as marketed by Elia and now Quidel, and you can see that in the same population there are fundamental differences. You can see that the red PlGF is lower in the Quidel and is different from the Roche PlGF, and this is probably explained by the slightly different assays and the different isoforms that they detect. So it's sort of an illustration that there are differences. Now, the clinical data on this is quite interesting. So the Roche ratio clearly is very good, and it does discriminate very nicely at those people who end up getting disease and ultimately needing delivery because of pregnancy problems. And here's a sort of survival curve of babies needing delivery when they have a bad ratio compared to a good ratio. Equally, the Quidel sample, this is one of our studies, if you look at PlGF, if it is very low, it discriminates a group that really do need delivery soon. In this case, levels under 12 resulted in delivery within a median time of 8 days, whereas if it was normal, well over 100, you would literally go months before there was a problem. So also very good clinical discrimination. Now, there are lots of clinical studies out there. I won't go into them, but I'll concentrate on comparing the different assays. So here are the number of publications that my group has produced over the years, everything from looking at the health economy of this, the prediction of it, but also looking at it in subgroups, for example, those who present with IUGR. We've been looking at different thresholds for different agents, and I won't have time to go into these, but they're there for you to look up if you wish. What I do want to do is concentrate on one of those papers. So this is the COMPARE study. And what we did is we took some samples that we'd had from another study in women who are at high risk of preeclampsia, and essentially we used three commercially available assays to compare the predictive ability on the same women. So we actually have a direct comparison with none of these confounders other than the fact that the assay is different. So here they are. You can see that the one marketed by PerkinElmer, the Delphia, the Quidel one now, the Triage and the Roche ratio. And we did the normal standard predictive statistics, but the problem is because of the difference in threshold, and we're not sure about whether they've set the sensitivity at the right level, the main thing to look at is the area under the curve, which essentially is a combination of all the sensitivity and specificity across the range. And the really important thing is they are identical. There's absolutely no difference in this group of women in predicting that these women went on to get preeclampsia and required delivery. What you do notice, though, that there are differences in the sensitivity and the specificity simply because the threshold they use are not the same. So, for example, the Roche assay will have a lower sensitivity and therefore its rule-out capabilities will be less than the others, but the price the price that goes with that is having an improved rule-in and therefore a higher specificity. So again, it doesn't mean they're different, it just happens that that ratio is set at a slightly different cut to the other companies. And you can see here, and this has been summarized by Alice Hurrell in a review article from our team in a very nice table looking at the various rule-in, rule-out cuts for the various biomarkers that are currently available on the market. And I think it really is a very clear lesson that there are no differences really in terms of the clinical acumen. So I'm going to finish off by just talking just about the conclusions from the various research we've done. I think the real lesson is these commercially available assays are not the same. So even though they may be called PlGF, the type of assay that they're actually measuring are different. And this is largely explained by the different assays having different affinities for different isoforms. Also, depending on which threshold that the original companies picked on their original clinical trials, which weren't always that big, they are then stuck with a threshold that's often different between the different assays. And so we have this further confounder, making it very difficult to compare. However, I can find no evidence that the ratio is superior to single markers that are currently available. In terms of prediction, there may be reasons why we want to measure soluble FLIT as a potential therapeutic target, and there are studies looking at this, but at the moment, in terms of prediction, there really are no differences. It's looking promising mainly as a rule-out biomarker. So the woman who turns up who has a normal level, you can reliably say she is not going to get preeclampsia, and certainly not in a sort of tight time frame that's likely to be serious. There's some value in the sort of abnormal levels indicating that your risk of preeclampsia is higher. That's perhaps not quite as good, and therefore the clinical acumen of doing that is still uncertain, and NICE in the UK is currently considering whether it should be recommended as a rule-in test as well. These biomarkers really don't seem to be valuable in women with established preeclampsia. Now obviously, depending on how good your clinical service is and where you are, it may be that the diagnostic properties of the agent are useful if you're in a place which has poor ability to diagnose, for example, in a low-income setting. However, I think in the UK, in the way we use it, there's very little added advantage in taking a biomarker in someone with established disease, and it shouldn't be used as a way of determining when and how to deliver someone, because it'll just be abnormal. You shouldn't deliver someone just because they have an abnormal biomarker. You should base it on normal clinical acumen that's been established over many years. What we do know is the biomarker is strongly related to fetal outcome in women who have preeclampsia, and there's some studies suggesting that it very reliably identifies those women liable to have a stillbirth, and those who do have a stillbirth have an abnormal level some months beforehand. It doesn't seem to be that useful in just isolated IUGR, and I think we have to be careful for that mission creep not to be using the biomarker in other populations. Ultimately, how we use this product or which product we take on will depend largely on the cost and its clinical utility. So how easy is it to use? Where do we want to use it? Do we want to use it as a screen in large numbers for targeting aspirin, or do we want to use it by the bedside in the middle of the night? And obviously how the equipment works and that point of care aspects may start to matter depending on your interest. I guess there's also this need to standardize across platforms. Now, it's very unlikely the commercial companies will do that, but we as clinicians need to be aware that we're not comparing apples with apples, and we've got to think carefully about what it is we're measuring, and we shouldn't fall into the trap just because we've seen one clinical study that looks good that A is better than B. As far as I can see, they're all very good and they're very comparable. Thank you very much.